Ladies and gentlemen, we now move ahead to the next segment, that's the Symposium on Congestive Heart Failure, Systolic and Diastolic Management Strategies in 2012. We've got 2 lectures for 12 minutes each, followed by about 6 minutes of discussion. Our speakers will be Dr. A.K. Omar on echocardiographic assessment and Dr. Bindu Kumar Kansupada on the role of automated implantable cardioverter defibrillators. May I straightaway invite our chairpersons. Please welcome, in the order of appearance, Dr. P.N.S. Haritha, Dr. K.K. Kapoor, Dr. Ravikant Mishra, and Dr. S.C. Govind. May I request the chairpersons to invite Dr. Omar and set the proceedings in progress. Since this is a symposium, we will have a discussion at the end of both the lectures.
We can start with the first speaker. This is going to be an interesting symposium on congestive heart failure, systolic and diastolic. And Dr. A.K. Omar will be the first speaker who will do this echocardiographic assessment.
Thank you, Dr. Kapoor, Dr. Khanna, and thanks, Dr. Chopra, to inviting me for this important symposium. Like imaging techniques for management of heart failure, we all know that X-ray, radiography, nuclear testing, ultrasound, that is echo, and MRI are very important. So this helps in the diagnosis of systolic and diastolic heart failure, selection of medical devices, surgical treatment, care of advanced heart failure, stem cell therapy, and also device therapy for control of remodeling. What are the challenges? We have ability to identify heart failure at its earlier stages and to intervene. Invaluable tool to identify the patient at a risk for heart failure, that is aggressive prevention. Diagnosis and risk stratification, identify candidates for ICD and CRT. And it's a part of imaging armamentarium with MRI and nuclear and CTA. How it helps? It helps with the hemodynamics, the stroke volume, cardiac output, right atrial pressure, right ventricular systolic and PA pressure, PA diastolic pressure, all that can be calculated, and also the increased LA pressure. Overt heart failure, what we look into, the gold standard LV ejection fraction, LV volumes, LV shape, diastolic filling pressure, and infarct thickness, synchrony, mitral regurgitation, viability, less and less. Time is less. So let's look into how much we can cover it. The LV ejection fraction, all we know that the various methods we all know about that, including from the M mode, going to the Simpson method, and ultimately ending with the visual result, which is almost similar what we get with the invasive methods. So what are the limitations of LV ejection fraction? Is the geometric dependent, load dependent, difficult at low and high heart rate, left ventral branch block, presence of mitral regurgitation, expertise of course is required, and prognostic value for ejection fraction is less, around 50 or more than 50% of ejection fraction. So what are the surrogates? If we not EF, what we will have to look into? There are a couple of parameters like T index, that is the index of myocardial performance, which depends on ejection time, and the the isovolumic contraction time and isovolumic relaxation time. That's how you calculate, and this all parameters we can get with the echo. They are reproducible, easily obtainable, closely correlates with the invasive measures, independent of heart rate and LV geometry. Another thing which we can do is MRZ DPDT. It's an underutilized indicator of LV function, while EF is affected by afterload, MR DPDT is afterload independent, but is influenced by the preload. It is major contractility in the isovolumic contraction phase and can be used in a patient with measurable, only patient with the measurable mitral regurgitation. So what are the limitations? I told you this MR DP depend on the presence of enough MR to obtain well-defined curve. Another thing which we look into is the cardiac output. We all know that the cardiac output we can calculate in the with the LVOT area, and then look into the VT at the LVOT as well as the across the aortic valve, and in fact from the other valves also. It's a simple non-invasive method of measuring cardiac output which correlates well with the thermodilution method. Of course, the problems are there if you don't get the adequate window, and the angle dependency is there. So another parameter is the LV mass quantification, which can easily be done with the echo. If you look into the volumes, we go to volumes. If you look into the volume, all patients of the congestive failure, but these red bars are the volumes. If you look into the volumes, if the systolic volume increases, the prognosis is poor. Same is shape with the spherical shape. If you look into the sphericity index, the more spherical the LV, the prognosis is not good. So looking into this, if we have heart failure, we have to look into the coronary artery disease, look into the valve motions, segmental valve motion defects, and segmental LV function. That is the typical 16 or 17 segments, how we measure, and we look into the contractility of the heart. This we have looked into by the what we see normally. But for the technical point of view, if you look into acoustic quantification, this the automated detection of the endocardial border, how it can calculate the ejection fraction, and its beauty is that it's online and beat to beat you can see that. Newer techniques are the tissue Doppler imaging, that like myocardial velocity, strain imaging, strain rate, measurement of dysynchrony. If you look into this, this is the annular movement of the mitral valve along the vertical axis, and you can calculate the ejection fraction which matches with the ejection fraction. Same is the strain rate imaging, by which also we can the volumes as well as ejection fraction. This is 2D strain rate. The global strain, that the strain has incremental value in standard indices, and global strain and LV ejection fraction have loose association. Scatter is less in global strain derived parameter than the standard volume derived parameters. This is the strain rate versus the ejection fraction, DPDT, which is quite correlated. The global strain, if we add the global strain parameter, you can see the prognosis, you can give the better prognosis. The same way the tissue tracking, either in the 2-dimensional or 3-dimensional view, is the new technique like speckle tracking, involves identification of the multiple unique patterns of echocardiographic pixel intensity that are automatically tracked throughout cardiac cycles. Its angular displacement of the pixels are plotted against the time in apex with the LV segment and the base. This method is not angle dependent and compares favorably to MRI. This is how we calculate the ejection fraction in 3D speckle, and this is comparable to MRI. So if you look into the shape of the myocardium, particularly after the infarction, is whatever the method you use, either M mode or 2D Simpson or whatever, is not going to correct ejection fraction. Then comes the 3D echocardiography, which is the art of today. This is matrix array transducer, has capability to acquire real-time full volume imaging. No geometric assumptions are required. Accurate global and regional functions are assessed which are correlating to MRI. 3D can also help in recognizing motion dysynchrony by plotting motion against time. This is how the ejection fraction in various views, you don't have to change the transducer or views. This is how you can calculate the segmental abnormalities, and also you can look into the dysynchrony. If you look into this red bars are the diastolic volume, systolic volume and ejection fraction, and which are very correlating with the 3D echo and derived parameters, either ejection fraction or systolic or diastolic, when you use 3D with contrast, which is less if you use with the 3D alone, or even less if you use 2D contrast or 2D echo. So, a few words about diastolic dysfunction. We all know that the diastolic dysfunction we measure by transmitral inflow pattern, that the EA, deceleration slope, mitral annulus velocity by TDI, that is E oblique E prime, and pulmonary venous flow, and the M mode color Doppler of mitral inflow. This is the normal pattern where we can see the E is taller than A and the deceleration slope is more than 220. The E dash can guess pulmonary capillary wedge pressure, and if E oblique E prime is more than 15, wedge pressure is more than 20. That's all we know about. Let's go to pulmonary venous flow. Here the systolic and diastolic flow. If you look into this, systolic waves are prominent, but if the systolic wave becomes shorter, that is a very good parameter for the diastolic dysfunction. That is again the left atrial volume. If it is more than 34 or 34, it's a moderate, it's actually long-term diastolic dysfunction is present. In same way we look into the velocities of E prime. The lesser the E prime, the worse prognosis. If you look into the reversibility of grade 4, if the reversibility is not there, prognosis is worst. If reversibility is there, prognosis is good. This is how we can look into the approach to grade the diastolic dysfunction. We have to look into the LA volume, we have to look into E prime and grade the diastolic dysfunction. Other things which we use the echo is the mitral valve surgery and interventions, and you can look into the stretching of the mitral valve annulus and malcoaptation of the mitral leaflets, tethering of the mitral valve leaflets. All this can be looked, formed, and surgery or interventions can be guided or planned. Ventricular reconstruction surgery, especially for apical aneurysms in patients with ischemic heart failure. Decision making depends on the determination of a kinetic and dyskinetic area, thinning of myocardium, depressed ejection fraction and presence of MR. Ventricular assist devices, preoperative echo to recognize the coexisting valve disease, intracardiac shunt, RV dysfunction, post-implant detection of the thrombus or other causes of inflow cannular obstruction, and significant inflow and outflow cannular regurgitation. Same way, CRT can also be guided by there are parameters to use for the CRT derived from the echo. Echocardiography critically patient to identify the candidate for the life-saving therapy of ICD. Careful assessment of LV ejection by biplane symptoms or use of contrast in 3D or 2D can help us. So, friends, the echocardiography is to stay with for the congestive cardiac failure, is well qualified to meet growing need for a non-invasive imaging in heart failure population. Doppler measurements help in recognizing and managing the hemodynamics. Thank you.
Thank you very much, Dr. Omar, for giving us a very lucid and good presentation on the role of echocardiography in the assessment and management of congestive cardiac failure. This topic is now open to the House for discussion. Anyone would like to raise any point? We have got two minutes for questions. Okay, we can take the questions afterwards and we can go to the next topic.
Yeah, for the next topic I would invite Dr. Vinod Kumar from US on the role of ICD in congestive heart failure. I'm sorry, Dr. Bindu Kumar.